So our next speaker is Dr. Nitesh Gehlot from AIMS Jodhpur. And so again, he will be talking on the massive cuff tear.
So I think this is the fourth different scenario of massive cuff tears. We've seen lower trap transfers, SCRs, arthroscopic transfers, and I think Nitesh will speak on a different dimension.
Good evening, everyone. I am Dr. Nitesh Gehlot. So my case is a patient who had a massive posterior superior rotator cuff tear. Some demographic details about the patient: 55-year-old male with a chief complaint of pain in the right side for around a year, progressive restriction of movement for years, and difficulty in lifting weight with right upper limb for last 9 months. This was the passive and active range of motions on examination. There was an external rotation lag sign present in adduction, weakness in external rotation, and adduction was painful and restricted. The active range of motion was severely restricted in abduction also, and external rotation was severely reduced. These were the radiology preoperative. There is a proximal migration of the humeral head seen on the true AP view. Not a lot of degeneration. The preoperative MRI that shows the Pate grade 3 retraction of the supraspinatus. Tangent sign was positive for both the supraspinatus and the infraspinatus. There was a lot of atrophy of infraspinatus with Gottlieb grade fatty infiltration grade 3. The T1 images, axial sections, there is tear of the infraspinatus that can be seen and with retraction. So the diagnosis that we came upon was posterior superior rotator cuff tear of the right shoulder involving the supraspinatus and infraspinatus. Now what should be the plan? I would like to ask the audience what should be the best course of action for this patient.
So do you want the ARS to be put up?
Yes.
Can you please put up the ARS? And please be ready with your voting pads as soon as the ARS is up. Is this the question you wanted
pose
to
the
ask?
slide only.
Okay. So I think we can first vote on this since this is on the screen.
So this was the question actually, what are the indications for the latissimus dorsi transfer?
Okay.
So for the younger patient we do, for the irreparable massive cuff tear we do, for Gottlieb grade 3 fatty infiltration. For Hamada grade 3 more than 2, that is not a contraindication. Coming to this plan, I will just ask a raise of hand for this. For arthroscopic partial rotator cuff repair, you can remove the ARS. ARS hata dijiye.
So we can have a show of hands.
Yeah. So for arthroscopic partial rotator cuff repair, partial repair plus superior capsular reconstruction, or the muscle transfer, latissimus dorsi or lower trapezius transfer. For people for latissimus dorsi transfer and people for lower trapezius transfer. Okay, so we have a couple of hands for lower trapezius. I went ahead with my plan going in for this patient was arthroscopic partial rotator cuff repair because there was Pate grade 3 retraction of both the supraspinatus and infraspinatus. I wasn't sure that I would be able to bring both these tendons to the footprint and do a successful repair. And also the muscle tendon tissue had to be assessed intraoperatively. Plus minus I had kept latissimus dorsi transfer, tendon transfer for infraspinatus. Even if I won't be able to do a supraspinatus repair, I would do an tendon transfer for infraspinatus so that the force couple is maintained and the patient is able, and the glenoid humerus head is centered on the glenoid.
Nitesh, before you go ahead, I'd just like opinion from Shirish. He said that he raised his hand for tendon transfer and raised for lower trapezius. So Shirish, obviously you've done latissimus dorsi before and now you have shifted to lower trapezius. Despite the fact that you have to take another tendon, why do you still prefer the lower trapezius over lat dorsi? Can somebody hand a mic as well to Shirish?
No, I think technically I find doing lower trapezius easier. You don't have to deal with neurovascular structure. Okay. Action is synergistic and the pull of direction is very easy to recreate. And being a knee surgeon as well, it's very easy to take a hamstring graft. So I find it more surgeon friendly than lat dorsi.
Okay.
As per the restoration of function post-operatively, have you found any difference between the lower trapezius and the latissimus dorsi?
I haven't done many lat dorsi, frankly speaking. And I'm happy with my small number of low trap transfer. I'm pretty happy with that.
Okay. Some literature. This is the latest paper for the tendon transfer for irreparable rotator cuff tears. For irreparable posterior superior rotator cuff tears, the tendons we call tears we call as irreparable tears are in which we are not able to achieve fixation in less than 60 degree of abduction, at least stage 3 fatty infiltration, acromial-humeral distance less than 7 mm, and static migration of the humeral head proximally. No radiographic indications or limited glenohumeral arthritis should be present. Irreparable supraspinatus and infraspinatus tendons are there. The Gottlieb grade 3 and 4 fatty infiltration are present. That are indications. But the subscapularis should be intact. The subscapularis should not be torn. If it is torn, it should be reparable. If it is not reparable, then you cannot do a posterior tendon transfer, because then the force couple would not be maintained. Atrophy of teres minor has been associated with worse post-operative restoration of axonal rotation. That has to be kept in mind. So the ideal candidate, young motivated patient, small degenerative changes in the glenohumeral joint, preferably Hamada grade 1 and 2 degeneration, massive irreparable tears of infraspinatus, significant atrophy, more than 2 according to Tomasu classification, and more than 2 according to Gottlieb fatty infiltration, and definitely a functional deficit in the form of reduced axonal rotation. What I did in this case, first the glenohumeral inspection was done, and here the tendon tear was started from the posterior superior. Anteriorly till the biceps tendon. The subscap was a bit frayed, but I checked that it was not torn completely, and the superior part was still intact. So there was no need to repair it. Biceps tenotomy was done because patient had anterior shoulder pain. Shifting to the subacromial space, there was a large tear. And the next thing that I went on to do extensive release of the supraspinatus, both below the tendon and above the tendon. A lot of release was done. After the release, I was able to bring the supraspinatus near to the footprint, and with a slight medialization, I was able to do a double row repair. That much pulling from the lateral portal I was able to do. But I was still not sure about the quality of the infraspinatus. The tendon was very thin, although I was able to bring the tendon towards the footprint because supraspinatus was coming with it. But I was not able, the tendon quality was not good. So I was not sure whether my ankles would hold into the tendon. So I decided intraoperatively to go for a supraspinatus repair, double row repair, along with a latissimus dorsi tendon transfer. So this was the incision, axillary incision. I do my arthroscopy in lateral position. So this was the posterior axillary incision was given, lat dorsi was harvested, and the sutures, whip stitches were taken with non-absorbable sutures. They were passed below the deltoid into the subacromial space, and they were passed anteriorly taken out through the anterior portal, so to pull the tendon inside after the repair was done. Then I went ahead with the supraspinatus repair. For the posterior anchors, I had repaired the supraspinatus. I left one because they were double loaded anchors. I left one suture in both the anchors to repair down the latissimus dorsi tendon after it has been pulled into the final position. So this was the final repair was done. The lat dorsi was pulled anteriorly from the anterior portal on the inferior to superior. Then the anteriorly, the blue whip stitches, they were pulled, they were fixed into the bone with a knotless anchor. And to bring down the lat dorsi tendon on the bone, the sutures from the posterior ankles was passed above it and then sutured down. This was the final repair. The supraspinatus was completely repaired in double row, and then this was the lat dorsi tendon coming from posteriorly. This was the post-op X-ray. As you can see, the acromial-humeral distance has now been maintained. The humerus head has come down. At 10 months, the patient is able to do axial rotation on the right side and is able to do forward elevation. And there is no pain as of now, and still the follow-up is going on. And I would like to at least follow up for 1 or 2 years so that I am confirmed that the tendon is not working. But axial rotation power has been restored as of now. Thank you.
Good presentation, Nitesh. So I would like to have you